Hello, and thank you for taking an interest in watching our presentation on emotional resilience and the anxious student. I'm Dr. Allison Durham, and with me today is Dr. Deborah George. We're both directors of clinical education at the University of Findlay. Dr. George is the DC for the weekend PTA to DPT Bridge program, and I am the DC for the traditional program. So we're bringing part one to you, and this is supported by the Northwest Ohio Clinical Education Consortium. And we would like to just give you information on how to manage or identify the anxious student. And we have Karen Westrick, who is our licensed counselor here on campus, that will be speaking as well during this presentation. So let's go ahead and get started. So the objective of this presentation is really just to demonstrate an appreciation for the need to address mental health issues in our students, particularly anxiety, as we're seeing a rise of it in our younger population, and explain the common behaviors that are exhibited by a student with anxiety, and then explain, obviously, potential solutions to help these students with the anxiety and mental issues. We'll also be developing skills with providing a supportive approach to mentoring students during clinical education. So why are we talking about this? Well, there has been evidence on the growth of mental health issues in our students, especially our students that are in the millennial generation and the Gen X generation. The American Psychological Association in 2018 put out data showing a percentage of individuals reporting excellent or good mental health. And as you can see here, the black bar represents the percentage of people that feel that they have good mental health. As you can see, older adults, 74% would say they have good or excellent mental health. You can see as we go down to our younger individuals, that black bar tends to dwindle. Here we have millennials, ages 22 through 37, and the Gen Z generation, that's ages 15 to 21. These are the students we will be working with in the short future. You can see only 45% of these individuals can say that they feel that they have excellent or good mental health, and that's why we're touching on this subject today. When knowing what is it that tops as far as diagnosis of what mental health means, in the last 3 years, well, between 2014 and 2017, in the 3-year span, we saw a 31% climb in major depression among our millennials. Now here, millennials is defined as 21 through 36 years in age. So in 2017, the Blue Cross Blue Shield, the Health of the Millennials, they took data showing that major depression was sharply on the rise. And again, you might be asking, well, why? There are a number of theories, and once I got to researching it, I saw 3 major theories that popped up repeatedly. Number one was social media and technology. Our students are consistently faced with negative news, whether it be the coronavirus in their face every day, or massive school shootings or public shootings, terrorist attacks. These students are faced with it at their fingertips on their phones every day, all day long. Also, social media, Facebook, Instagram, they're making comparisons to their peers, maybe to older people, and they are not feeling good about themselves from a day-to-day basis due to these comparisons. And then just actual less human interaction leading to poor development of communication and socialization skills. You want to order a pizza? It's right at your fingertips just to order online. No need to interact over the phone with someone else to get that order in. So we're just seeing some of these piling up as to one theory why students may not know how to deal with stress adequately and why they may be depressed. Number two, we've all heard of helicopter parenting. There's a new version of lawnmower parenting out there where the parents are more invested in their children, in their education, in their future than parents ever were before. And they are mowing down the child's conflicts to make them succeed, to get them through college. More students are going through college. It's a higher stress environment, and the parents are financially, a lot of times, responsible for the children. So this really leads to the child not developing communication or problem solving. It's much easier now to mow down a child's conflict with technology and an email versus interacting with someone face to face. And then thirdly, it's just there's more acknowledgement, which is a good thing. Our counselors here on campus take in a lot more students, and they broadcast what they can offer our students as far as managing anxiety and depression. So being that there's more awareness and that it's more accepted and mental health issues are more accepted, we just see an actual increase in reporting of mental health issues, which may be the reason why depression is on the rise, just because it's being reported more. Because of this, ACAPT, which is our American Council Academy of Physical Therapy, which is just a part of the American Physical Therapy Association, actually acknowledged that research is showing a rise in student stress, not only among individuals that are not in school, but those who are particularly going through the PT program and are in the clinical setting, where they're having to interact with people for the first time professionally. And they put together a task force, which is to enhance academic programs' awareness of the mental health and wellness needs of students and future clinicians. And they actually created objectives of this task force because they want to teach clinicians and educators on how to manage students and identify students with this problem. They really want to improve a baseline understanding of the challenges to students and clinicians' well-being, raise the visibility of clinician stress and burnout, and provide us resources and tools to help manage it. And they plan to do a lot of research on this to give us the best information possible to help these students.
So now we're going to talk a little bit about some of the basic concepts that we want you to be aware of before we get into talking about who is the anxious student and what some of the possible solutions are to help with working with the anxious student. First of all, anxiety. Anxiety is a very basic human emotion whereby the individual is apprehensive about uncertain outcomes. All of us are exposed to having some anxiety. Now, there are two different types of anxiety. There's state versus trait anxiety. State anxiety is anxiety due to a specific situation that may have a trigger. So in the clinical setting, we may not be aware of the fact that the student is going to be responding in a highly anxious fashion. This would be an example of a state anxiety due to what is occurring within the clinical environment. And then there is what's known as trait anxiety. It's a chronic, pervasive anxiety not triggered by a specific event. Now, that type of anxiety we may be aware of back at the institution. However, we are limited by what we can tell our clinical faculty with regards to the protection of our students' information. And in part two, we will talk a little bit more about those restrictions and what we do back at the academic institution with helping our students. And then there is resilience. This is something that is important for all of our students. It's basically a process by which people adapt to different changes or crises, which is not a character trait, but can be learned. It's a way to deal with that anxious situation. And this is something that we try to help our students with so that they are successful in that clinical environment. So now we'd like to ask, who is that anxious student? There are different ways in which we can look at that anxious student. We can think about what they might say. We can think about how they feel, what they do, or what they think. Pause for a minute and think about what are some of the things, if you were very anxious, that you might say or that your student might say if they were anxious. They might say, I don't know it, not sure. What do you think? They might feel panic, fear, uneasiness, dread. They might even get nauseous. They might have sweaty hands, shortness of breath, dry mouth, very big eyes. They might feel tense. They might think, I'm not good enough. I'm stupid. I'm going to fail this clinical experience. My mind basically goes blank when I'm asked questions. This is a picture of that anxious student. Now let's look back at the clinical site. That student might appear to be very shy, timid. They might appear to choose to eat alone, when in fact, internally, they desperately want to be part of the team, and they might need to be asked to join in with the team at lunch. They may appear to be asking questions over and over during the history taking, or they might not be very complete with the kinds of questions that they are asking. They may be feeling internally overwhelmed with wanting to include every possible question. They may appear to take excessive amounts of time with their documentation, when in fact, they're trying to be perfect with that note. They want to get your approval as a clinical instructor, and so they may lose sight of the time. They may be working with a patient in the acute care system and focus on the tubes rather than the patient themselves. And internally, they may be so fearful of harming the patient by pulling out those tubes. They may appear to lack creativity with the structuring of their exercises. And internally, they may be wanting to mimic what the team has done because they want to do it right, so to speak.
So Dr. George and I thought it would be really powerful if we had actual students give their perspectives on what triggers their anxiety or their stress in the clinic. And so we asked one of our countless students who've come to us anxious to give us an idea of what was going through her mind when she was experiencing anxiety. So let's take a listen to her thoughts.
I had such little confidence in myself because I felt intimidated by the situation I was in, and it really worsened throughout the clinical, especially as expectations became more unclear due to miscommunication. My nerves really increased throughout, which made it more difficult to prepare and feel confident in my work. I was mostly anxious because I felt like I was taking an exam for school. Basically, every time I would evaluate or treat a patient, it felt like she was waiting for me to make a mistake. It felt like there was a constant reminder I was not doing well. I also became very anxious due to her close proximity with all of the treatments and evals. Because she didn't give me any physical space, it made me feel like she wasn't confident in me, which made it hard to be confident in myself. Every good job she had to say to me was followed by a but, which turned the good job into only partially correct in my mind. I also had very poor self-care throughout the experience. I wasn't sleeping well because I was staying up late preparing for the next day and doing research on the things that she asked me. I was exhausted overall, and I quit doing the things that I enjoyed outside of the clinic.
So pause and think, what could the clinical instructor, the site coordinator, do to help alleviate the stress in this particular student? Well, let's have our students answer that. So we asked another student to give us their perspective on the potential solutions that the clinical instructor, the site coordinator, could have done to alleviate some of her stress and anxiety that was brought on during the clinical experience. Let's take a listen to what this student had to say.
Taking a moment to listen to my input as a student experiencing anxiety. As of right now, I have clinical experience in acute, skilled nursing, and outpatient care. Having more insight now and looking back on those experiences, especially in acute care, there would have been some things I would have asked for. Firstly, I felt that any concern I had as a student was attributed to my anxiety, and it wasn't always given the attention that it deserved. I felt that being honest had unintentionally separated me from my CI's past students and her experiences with those students. So taking a moment to address concerns or discomfort means so much because it means I can take that concern off replay in my mind. I I perform really well with frequent feedback, so making the time to address questions throughout the day helps keep my day running smoothly. Secondly, I need a CI to be realistic with me when discussing outcomes of making a mistake of any nature. In acute care, we know that patients are at their most fragile state. Taking a moment to discuss what happens when something doesn't go as planned could mean so much to me. Who do I call for? What do I say? How do I help? And most importantly, just assure me that I'm safe and that the patient is going to be safe and no one is going to die at my hand. That's important to me. This may be intuitive for most, but it isn't always addressed aloud, and that could be something that would make a significant difference for me. Lastly, I would love to take a moment to get to know you. My previous clinicals didn't have orientation time allotted into their schedule and asked me to arrive 10 to 15 minutes before meeting with our first patient. I would much rather meet with my CI, take a couple minutes to get to know each other, discuss any past experiences I've had and any concerns I have for my time at their facility. I think that is significantly more beneficial than getting to know each other along the way, as it can lead to and has led to misunderstandings and frustration later on in the experience. I know that was a lot to cover in a few minutes, but I really appreciate you taking the time to make improvements to my experience and other students with anxiety and their experience.
Okay, and now we're going to hear the perspective of the mental health counselor, Karen Westrick. I'll be asking her a series of questions related to the clinical environment.
First, I'd like to thank Ms. Karen Westrick for agreeing to do this interview concerning performance anxiety and emotional resilience. Karen, would you like to start by sharing your background?
Sure. I have a bachelor's degree in psychology and a master's in counseling psychology, and I've been a licensed professional clinical counselor in Ohio for about 30 years. The bulk of that being here at the University of Findlay as director of the counseling services. Mm-hmm. So in Ohio, that license allows us to diagnose and treat and operate pretty much as you would see with other private practices.
Mm-hmm. So it sounds like you've worked quite a bit with college-age students, would
Absolutely.
you say? Excellent.
The majority of my career.
Excellent. So would you start by providing our audience with an understanding of some key words: stress, performance anxiety, and emotional resilience from your perspective?
Sure. So I think stress is something we're all familiar with, and I think the important thing about stress is that it comes and goes, and that's how we separate that from anxiety. Mm-hmm. Stress is very transient. It's a response we have to normal situations. So, you know, if I am feeling pressure at work to complete a project on a timeline, I might feel a heightened sense of stress. Mm-hmm. But when the project's done, that stress is probably going to dissipate until the next one comes along, or I learn to manage it differently. With anxiety, it's a little more, the performance anxiety in general is a little more of a perpetual, a little more of a chronic experience. It's a little more generalized to multiple settings. And it doesn't necessarily just go away because a situation changes. Emotional resilience, it's kind of a catchword now. And it should be. It's really kind of the foundation of our ability to cope, our ability to kind of roll with the punches, be adaptable to environments, changes, different stressors that come up. I use the example with students that I like. Hopefully it's an analogy that works for others. If you've ever been on a boat on the water, I'm prone to a little bit of seasickness, and I was given this advice, and of course I found a way to make it into an analogy for therapy. But if you're on a boat and you look out to the horizon, you don't feel the waves as much. You don't feel everything hitting at you. And you know, this is kind of the idea of resilience. Look at the big picture, learn to roll with it. If we're looking at every individual stress or change or conflict that comes up as those waves, we feel every one of those. And it's harder for us to adapt when we don't know what's coming. But if we look at the big picture, if we know that we have the ability to roll through whatever comes our way, just float with it, then we do a little bit better overall.
Excellent, excellent. Now let's have a little bit more specific picture of the student who has performance anxiety. What are the characteristics of performance anxiety that a clinical instructor who's working with a student physical therapist would most likely observe? So give, from your perspective, what that person would probably see in their student.
Okay. So performance anxiety, we all can experience that. It's a very common experience. Think public speaking, think, your driver's ed test, your recitals, those kind of things. And sometimes it's a very beneficial piece, right? It's that ability to get up for the game, to be able to have a little bit of zest before we go and perform. So in a certain way, it's a functional, healthy kind of precedent to get us going. Where it gets into difficulty is where it might cross into a little more persistent social anxiety. And that's really what we see with some of the performance anxiety. If it's not remitting, it's probably a little different. So performance anxiety, foundation of that is really this idea of I'm being judged. So what are people thinking of me? Are they approving of this? Or, am I being liked? That's a big thing. Will I be pleasing to other people? So that fear of being judged is the foundation of a performance anxiety. So let's take a student in a clinical setting. Day one, it would be very typical to expect that person to have some of those expected performance anxieties. I'm going to have a little butterfly in my stomach. I'm going to want my CI to think that I'm ready and able, and I'm going to want to perform well. Somebody with more of an anxiety feature of that might be persistent. It might follow them when they leave for the day. They may ruminate about it, like, what did I do? And they might overthink what I said, what I did, how it was evaluated. And it's really more of a scrutiny, a perception of a scrutiny that trips that into a little more of a problem.
So, in particular with anxiety, help me understand what is the difference between what's called state anxiety versus trait anxiety?
Sure.
And in particular, how does it affect the student and their performance?
Sure. So state and trait are whether they are a transient situation or a little more of a perpetual chronic situation. So a state anxiety might be, I had a near miss fender bender driving in today, and that moment may be residual for a few minutes. I might feel a heightened sense of anxiety. It's very connected to that state, it's transient, and it passes. Trait anxiety, we're really looking at some personality features or characteristics that are stable over time. So kind of the difference between weather and climate. The weather can change, but I can generally say this is the climate for a certain area. So weather is your state, climate is your trait. With individuals with anxiety, we do see some clusters of personality characteristics that tend to show up more often for those individuals. Things like perfectionism, and we see that on the rise. People don't want to have a learning curve, they want to be an expert. So we see perfectionism as part of that anxiety trait. We also see a sense of a need for control, and different from being controlling, it's just they want their world to be predictable, so I need to have some known, some familiar things, some anticipated things, so it lessens the anxiety. And also then another feature, another trait for individuals prone to anxiety is that sense of approval seeking, people pleasing. I need validation, and that can sometimes interfere.
And sometimes they may understand something, but they still need to have that approval. So they might say something that they might have a question to their CI, and yet it's not really a question, but they want approval. Do you see that sometimes happening too?
Absolutely. Reassurance.
Yeah.
Yeah, kind of a sense of reassurance.
Okay, now what are the task conditions that can affect the experience and the expression of anxiety for the student, in particular the student who's in the clinic and they're performing and the clinical instructor is watching and observing that student?
Sure. So over the years I've had interaction with a number of students going to different placements. So there are some things that CIs can be aware of. One of the things I think is to see this as kind of a gradual increase of skill sets and expectations as opposed to a day one. People with anxiety or performance anxiety expecting that perfection will expect that they need to perform as their CI is performing on day one, which is unrealistic. So some of the things you can think of are time, space, reassurance. If we think of timed events, putting somebody under a clock, this should be done by now, that might heighten anxiety. And certainly that's a fair expectation over time, but something that you'd probably want to lead into and guide a little bit. We also can look at a little bit of the space issue, right? Like a personal space. So we go back to that fear of being scrutinized, fear of being negatively evaluated. And then with anxiety, we have lots of filters in our mind, we personalize little behaviors from somebody else. So with those kind of filters, that fear of scrutiny gets very magnified. So perhaps giving them a little physical distance rather than, hovering or being, within a few inches of each other. So maybe being a little bit on the outside of the hallway or at the edge of the door as opposed to right with them and the patient, giving them a little space. I think going along with the space issue, some environments, I think there's collaborative teamwork and other disciplines available. Perhaps that's not day one or week one. That might be something we grow into, so there's not this sense of being spotlighted. Another thing that I would also suggest is kind of the concept of see one, do one. So when we think of individuals wanting to perform and wanting to please and wanting to be approved of with their skill set, sometimes being able to see what is expected, have the CI do an evaluation and then allow the student to do the evaluation or the subtext of the evaluation. Sometimes that's helpful, gives them a little more sense of control and over what those expectations are.
Very good. So the next question I think has already been answered. The next question had to do with what the clinical instructor can do. Let me paraphrase what you said and help me know if there's anything additional. But what I heard was time, space, and reassurance. Those three are the key elements with working with a student that does have the performance anxiety. I very much understand about the time issue and how we want to flow the student from day one to the end of week 8, so to speak. You want to gradually introduce things from more simpler to more complex. And you want to then, as far as the space goes, give them the space as much as you are able to do within the confines of making sure that the patient is safe, of course, but as you mentioned, not being on their back. I think along with that, would you think it would be fair to say not just physically giving space, but also when you as a clinical instructor might be interjecting your own thoughts? Do you think that they should give the student time to really work with the patient before they give the thoughts and maybe a little bit later give their thoughts? Or should they give their thoughts right there, right in front of the patient? What do you think about that?
I think it's probably going to be different for some students, but in general I would say if you're giving the student the ability to function, a little breathing room, correcting them privately, giving them suggestions, critique privately, to do that publicly, especially early on into their experience, I think to do that in front of the patient would probably magnify their anxiety a little bit.
Yes.
Feels a little more of the scrutiny. The patient won't have trust in me. They think I'm doing a poor job. And what happens is when those filters get engaged, the focus on their cognitive, their clinical skills is getting divided and shifted with what do they think of me, how am I doing, what is this patient thinking? And we really want them to not be flooded with this filter. We want them to be able to function in their clinical skill set.
And then I love the last point that you gave about the reassurance. I think it's so important to look for whatever positives the clinical instructor can see about the student and give them those positives, give them the reassurance that they are moving along as they need to be moving along,
Absolutely.
so to speak. So
some of the things that I would suggest is the idea of asking them, what did you hear me say? Because if those filters are engaged, if they're flooded with cortisol that first week and they're processing things, perhaps maybe personalizing some things, to reflect, what did you hear me say? Well, I heard you say that you think I'm not ready for this. No, what I need you to do is work on skill A. And we have time for clarification with that. The other part about this is also asking the students, you know, what is working for you? Because clinical settings can sometimes take away their already established coping skills. I can't leave the facility when I want to. I can't go get a drink anytime I want. I can't go to the bathroom. I'm around people. I can't be alone. And those might be coping skills that are limited. So asking the student, you know, what do you need from us? To let them know that this isn't something that's being negatively judged, but we want to collaborate and work together for their success.
Very good. Okay, let's shift our focus a bit to emotional resilience in general. How can we promote emotional resilience in our students? You know, our students are with us for a number of years in the physical therapy program. What is it that we can do or promote with our students so that they truly are ready for doing this clinical affiliation?
I think one of the foundation things that we all need to do is to remember that we have coping and we have resilience. One of the phrases probably every one of my clients hear from me is, you're upright and breathing, right? You are sitting here, you are functioning, you have coping, or you wouldn't have made it this far. So to really kind of highlight the skill sets that they do have that work for them, I think that's an important thing. I think another thing is to be self-accepting. You know, that we all have deficits. That doesn't mean that I'm being judged or that I'm less valuable as a person or less capable in the big picture, but there's things that we all need to work on. And, you know, if a CI can approach that with, you know, their own self-acceptance and their own ability to talk about these things, that can help model for the students that it's okay to have an area of weakness, that it's not about perfection. So I think that's important. And I also think probably underrated is having a little humor about some of that. I think it's important that we can laugh at our own idiosyncrasies, that we can, you know, understand that we're all part of this human experience, and we don't know everybody else's story, but we all know that we have one, right? Like we all have something that we're insecure about. So having a little humor about those things, I think, is important. A practical skill that I think we can reinforce are things like reframing. So if I have a situation like, oh, that was a total bust. No, there was one part of that didn't go well, but X, Y, and Z was pretty successful. That's a nice reframe on that, as opposed to generalizing it to success or failure kind of dichotomy.
That's an excellent technique that I think the clinical instructors certainly can use to help build to the next experience that they might have with their patient.
Absolutely.
So, very good. So, does the literature demonstrate that anxiety can lead to the development of other problems? If so, what other potential issues should we be aware of?
Yep. And this is why that resilience and coping is so important, because when we do have anxiety, even if it's chronic, those coping skills kind of keep it contained. We know that mental illness is kind of an opportunistic thing. What we see is about a 45% comorbidity. So if they are struggling with one mental health issue, it's about a 50-50 shot that they're going to be having something else that'll surface. And with anxiety, what we often see is chronic stress, that chronic anxiety, the inability to remit some of that makes them more vulnerable to depression. You know, imagine being anxious and depressed. They seem like they can't coexist. So when they do coexist, it's, I don't know if I'm up, I don't know if I'm down, I can't stop my thinking. It can be very, very debilitating. So treatable, but you know, certainly very interfering with their functioning. So if there's a reason to address anxiety early on, it's prevention of depression.
So when do you feel it would be appropriate to refer an individual who seems to be suffering from performance anxiety and or depression to the mental health professional?
I think the most obvious and the most significant one is if there's ever a question of safety. So if we are hearing a student make direct or indirect comments about life or death, this isn't worth it, I can't do this, I'd rather be dead than be here. those are pretty directly stated, but if we hear those things, we certainly need to have a conversation. And if a person is uncomfortable, there's somebody in your facility or somebody in your community that can ask those questions. That's an important thing to do. But secondary to safety, I always tell a student, if it is interfering with your function, if it is interfering with your quality of life, then those are times why not have some treatment on this to kind of learn how to manage it. So if it's interfering with sleep, I'm ruminating, I've had racing thoughts, I'm, maybe with depression, I'm not able to fall asleep, stay asleep. So, I'm getting a couple hours of sleep a night, my brain's not functioning, so every other symptom's going to flare, right? All those cognitive symptoms are going to flare because now I'm also not having adequate rest. If my nutrition, my appetite is changed, I'm losing weight, those kind of things are certainly basic functions that we would want to intercept and have some treatment with. If my ADLs aren't, kind of working where they should be, those are things that we want to kind of redirect them. But I think even just quality of life, right? Like, when was the last time you felt joy? And if you can't answer that question, then we need to do some evaluation on that.
Right.
And I think for the CIs, this doesn't always have to be referral to therapy. There are a lot of self-help things that students have available to them. Therapy's a great option, I'm a fan, but there are a lot of other options, right? Even things such as finding ways to regulate your sleep, changing your diet so you're doing things that are, sugar is certainly one of those things that exacerbates mental health issues. We're finding more and more out about that. We know that caffeine exacerbates, so starting your day with energy drinks and wondering why we're anxious and not sleeping, there's things that we can change there. And certainly using some of the available free apps for relaxation, mindfulness, those are all skills that help build that resilience, help kind of contain some of those anxiety symptoms.
Very good. I did have a recent experience with a student who lost his mother, and it was 3 months before he went on his affiliation. And I did speak with him about, should we postpone this? And of course he's like, no, this is my mother's wish to go. He did go to the clinical affiliation, and about 4 weeks into it, both myself and the clinical instructor felt that he needed to be on hold. And so what I wanted to say to the clinical instructors out there, that there may be a situation where it's not a failure, we're putting this on hold and we'll reset it, we'll start up again when the student is ready. And certainly he came back to school and went through 6 months more of classwork, which worked fine, and then he was ready. He was in a better place after 9 months, allowing himself to grieve, and did very successful with finishing up his affiliations. So I think sometimes we as instructors need to know that these sorts of things can be put on hold and we can restart. There's no reason to simply push the person through and give them an unsatisfactory grade. There's no reason for that, that we can stop and reset when that person's ready.
I think a humbling thing to remember for all of us, if we look at any given year, about 20% of us are dealing with a mental health issue. We look over the course of a lifetime, it's 1 out of 2. So what they're experiencing is no different than what we're going to experience. And it's not that we need to coddle them, but we do have to have compassion that their life doesn't begin and end with their classroom work, that there's other things that are still coming into play. And so often, even the presentation of anxiety, this isn't about maturity or readiness or skill set. It's other stuff that gets in the way of them being able to show you exactly the qualities that they have. And with some support, some reassurance, kind of some gradual exposure as opposed to flooding in that first week experience, that really allows them a chance for success.
Yes, I agree. I've learned a lot, and I hope our audience has also learned about this topic. Thank you.
Thank you.
So, as we heard from this mental health counselor, the take-home message is, of course, time. It's important to give time to our students. Allow them to learn the information, learn the skills, as well as develop their confidence. Give them space. They need to have a little bit more space in order to become themselves. Certainly you want to take in consideration the safety of our clients. That is priority as well. And then reassurance. Reassure our students with what they are doing correctly, and then give them some suggestions in order to move forward. In all these different sorts of things, we can work towards emotional resilience. And we'll talk a little bit more today with how we can foster emotional resilience, especially in the student that does have anxiety. So first of all, we can categorize it according to what the student can do, as well as what we can do as clinical educators. The student themselves, they need to know what are their limitations and what are their abilities, and effectively communicate that to the clinical instructors. There can be a help with the dialogue between the student and the clinical instructor by using those weekly reflections. So we do want our students to start off by saying, what are their strengths? What are their areas that they need to work on? And usually when you first start with them, they might be very broad in nature, and that's where you can help them by making it a little bit more specific. Get into the specific pieces of what they need to work on. And so you as a clinical instructor will learn what those limitations and abilities are with your student on an informal basis, but also formally by doing those weekly reflections. The student needs to keep a positive view of themselves, that they are a learner, that they're in this situation to learn to be entry-level therapists. And of course, it's important for us as clinical instructors to provide unconditional regard and to be supportive of our students. That doesn't mean that this is endless and you give them the world, so to speak. There does need to be benchmarks in place to help them to know what they need to do. It's important for the student to maintain the general health and well-being. As Karen had mentioned, they need to have attention to, are they eating properly? Are they sleeping? Are they doing some of the exercise routines or perhaps yoga that they normally do while at the clinical facility? And as a clinical educator, I think it's important for us to encourage that self-care. It's also important for the students to maintain supportive relationships, whether it be with family, friends, other classmates. And it's important for us to encourage those sorts of relationships and also encourage the students to be part of the team. A very simple way to do that is to encourage them to have lunch with you, to talk about things that are not necessarily related to the clinical site, but about them as a person in their life. It's important for the student to consider the situation that might have occurred and the other person's perspective. And so if there is a situation where the student is not considering the perspective of the clinical instructor, I would want to work with them as the DCE to make sure that that is occurring. But then it's also equally important for you as a clinical instructor to understand the student's perspective. What are some of the things that they have learned back at the academic institution? Or what have they learned just through general life situations? It's important for the student to understand the boundaries that are set by the clinical instructor. It may be that they wish for the student to only email up to a certain period of time or to ask questions in certain situations. It's important for them to understand what those boundaries are. And then it's important for you to explain it to the students so that they know what they can and cannot do. If there is a situation of conflict, it's important to use conflict resolution strategies in an appropriate fashion. So for example, always important to use I messages. I think that it's important for the situation to move forward by understanding what you are telling the student from your own perspective, and then to listen actively to the student to find out what their perspective is within that particular situation. And certainly, if there is a situation of conflict, it's always important to involve the DCE with that conversation. It's important when a student is starting to feel uncomfortable about how they're progressing for them to look at the whole picture, to take one day at a time to visualize what they want and move forward to that where they need to go. Learning is not like an on-off switch. It's a continuum. It may be that a student is on an 8-week clinical and they may need a couple more weeks. Or it may be that they need to have a whole entire remedial clinical before moving on to the next. And that's okay. That's part of learning. You know, we all learn at different rates. So it's important to understand that both from the student as well as the clinical instructor perspective. And it's important to come to terms with situations that you cannot change. For example, the student may have a dyslexia, and maybe they have to understand, okay, I have this issue with reading. I need to do X, Y, and Z to help me be successful as possible. And it's important for the CI to work with the student as well as the DCE, and in some cases as well as with the center coordinator to come up with the best solution for that situation. Now, as far as what happens back at the academic institution, we as DCEs have our own responsibilities to prepare our students to get to this point of readiness before they come out to you, and then once they come out to you, to give ongoing support. So for example, we are trying our hardest to get to know our students. And the way we get to know our students is through our team meetings or being instructors ourselves, where we are aware of what their strengths and weaknesses are through the lab practicals that we do provide. We also have started an integrated clinical education type program with the Bridge program, and then with our traditional program, they have other experiential learning opportunities to get to know the student in the clinical setting. But we discuss our students and we discuss what are their strengths and weaknesses, and then help to get them ready for you when they come out to their clinical instructors. We also, throughout the clinical experience, we like to look at how the student is progressing with those weekly reflections. And so if I do have a student that has issues, I will ask the student to send those weekly reflections to me before they share it with the CI, so that we can make sure they are truly itemizing some of the things that they need to work on in a very specific manner. Then we do a phone contact to hear more about what's going on with our students. And we ask questions to find out, how things are progressing. If need be, we may have to utilize a learning contract just so that everybody knows that, what are those areas that need to be worked on, so that we're all on the same page. It's also important for us as DCEs to show some unconditional positive regard to our students as well. And so when we do meet with them with selecting some of our placements, we will guide our students into choosing the clinical site that would best meet their needs. Certainly geography may be a big role, but also in addition to that, what the students' past experiences are, how they are in the academic institution. Those are things that will play a role with helping them with choosing their sites. And then we have them send out information packets that will include information about them, their own personal goals, along with the goals of the school. And so we have an open door policy, throughout the entire clinical experience. We do want you to either email us or call us and let us know if there are any concerns or issues that you want to discuss. Definitely, if there is an identified situation, we do want to have a formal check-in period every so often to make sure that things are working forward properly. With regards to health and well-being, again, we do our team meetings to talk about how our students are doing. Now, if there is a situation where we do have a student identified as having a dyslexia or perhaps anxiety, we will work with our Office of Accommodations and Inclusion, as well as we might work with the counseling services with our students. But when it comes to giving information to the clinical site, we have to have a written consent from our students in order to do so. And so what we can do is when we do make a phone call and see how our students are doing, we might ask specific things like, well, how is the student documenting? How is their spelling and language coming along? We're able to ask any questions that is related to the learning on that particular clinical site. And throughout, when we are interacting with our students, whether it be through email or phone call, we remind our students. We ask them, are you sleeping? Are you eating well? Are you taking time for yourself to do the things that you normally do? With regards to supportive relationships, while they're here on campus, certainly there is activity between the cohorts as well as with their classmates. They have mentors that they are assigned to, and certainly we as faculty support our students as much as we can. During the clinical experience, if I know that the student is highly anxious and is having some difficulties, I may indeed ask them, hey, when was the last time you were home? If you haven't been home for a while, I want you to go home that weekend, because I think it's important for them to have those supportive relationships. And then with regards to readiness, as far as attaining the other individuals' perspectives, we at the institution do have some group activities where we'll work up cases and the students can learn from other students. We also have, as mentioned before, some integrative ClinEd experiences where, again, they will get to know what the other person's perspectives might be. And certainly when they're out at the clinical site, we will encourage them to consider the perspective of the other team members that they are being exposed to. With regards to boundaries, it's really important for the students to know that there are always going to be boundaries with regards to what they are requesting, and that they need to comply to the various boundaries that are given to them. That will start off with each institution has their own student requirements, and we make sure that the student knows that they need to comply with those requirements. But then certainly, as they're on that institution, they need to be aware of what the policy and procedure manual states, and they need to comply to all those policies and procedures of the facility. With regards to conflict resolution, certainly at the university, our students are expected to be accountable for their behaviors, and that is something that we hold very serious with our students. And certainly, once they're on the clinical sites, that too continues that expectation. With regards to looking at the whole picture, the students start off with going through CPI training as well as understanding the syllabi and what is expected with the conclusion of that clinical experience. And that is continued throughout the experience. We continue to remind them of what is expected. And then finally, if there is unexpected circumstance that comes up, because as life happens, those unexpected circumstances will come up, we'll remind them of the attendance policy or the direct lines of communication that are appropriate to follow. And certainly with regards to the ongoing support, if need be, the student may have an extension at that clinical site, or it may mean that they have to have a remedial affiliation, or in some cases we may have to just simply stop the clinical affiliation and then reset it. For example, I've had students that have had loss of loved ones and they needed to simply stop because their emotions were getting in the way of their learning, and then we just simply reset it to another time period when they are ready. So, in summary, we are a team. We are a team with the student and all of us as clinical instructors coordinators as well as the directors of clinical education. We work together to provide the best clinical experience that we possibly can. And in the end, we hope to promote emotional resilience so that the student not only can carry out what they are doing within the clinical setting, but as a future physical therapist. Now, we will have a second part to this series. In the second part, we will talk a little bit more in detail about emotional resilience, as well as its antecedents and consequences. And then we'll get into giving some really great case studies for you to look at how to apply this information, and in particular, expose you a little bit more to what we need to go through with the Office of Accommodations and Inclusion.
Well, we want to thank you for watching our presentation. Again, if you have any questions about what we've offered during this presentation, please either call or email us. Our numbers are here, our email addresses are here. We'd love to hear from you.